Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Professor Adam Ahmed Adam. You are welcome to this lecture. It is about torch infections. The acronym TORCH is coined from the initials of T for toxoplasmosis, O for other infections like congenital syphilis, infections by varicella zoster, parvovirus B19, HIV, hepatitis B virus, and there may be others. R for rubella, C for cytomegalovirus, and H for herpes simplex virus. Torch infections are infectious diseases occurred by the embryo or the fetus from its infected mother during pregnancy or birth. They may cause embryonal, fetal, neonatal, childhood, and adulthood morbidity, that to say death or mortality diseases. I would like to mention here that the prognosis will become worse if the infection occurs early in pregnancy, except for herpes simplex virus. Now start the congenital toxoplasmosis. It is caused by the protozoan parasite Toxoplasma gondii. The disease is acquired by passage of tachyzoids. These are the rapidly dividing stages in the blood of the mother through the placenta. They cross the placenta from the infected mother to the embryo or fetus. The hosts of Toxoplasma gondii, there are definitive hosts. These are the felines, especially the domestic cats. And there are intermediate hosts. These are the warm-blooded animals, mammals, and birds, as you see in the picture, including humans. The mother is infected by ingestion of oocyst excreted in cat's feces or stool, so they can soil the fingers, soil the any ingestible material. And this is the main route of infection. The other, ingestion of raw or eating raw or undercooked meat or offal containing tissue cyst. Offal, the viscera of the animal, edible viscera, like liver, intestine, spleen. These may be containing tissue cysts. The tissue cysts may be containing brachiozoids, which are the slowly dividing stages. There are rare causes or routes of infection like organ transplant, blood transfusion, and unpasteurized milk, but these are rare. Congenital toxoplasmosis is also known as vertical because it comes from the mother to the baby, or transplacental, that the parasites cross the placenta from the blood of the mother to the baby in the uterus. The mother acquires protective immunity, so the mother can be immune, not transmitting the tachyzoids. If infected priorly, 4 months or more before conception, before becoming pregnant. If she is infected earlier, 4 months or more before becoming pregnant, she will be immune. The transplacental infection is enhanced when the mother is not immune, either not exposed to this infection previously or she is immunosuppressed. The tachyzoids, as I have mentioned, cross the placenta and infect the embryo or the fetus. I would like to mention that the prognosis, that to say the outcome of the infection, will become worse if the infection takes place in the early pregnancy, that is to say the first trimester. Congenital toxoplasmosis may lead to miscarriage, that's a loss of early pregnancy, stillbirth, born full-time but dead, small for dead, The newborn will be small for the gestational age, that to say the duration of pregnancy, live birth with congenital defect, and also can be born apparently healthy, but the defects may manifest later in childhood or even adulthood. There are classic traits, three things, of congenital toxoplasmosis. One, chorioretinitis, that inflammation of the retina leading to visual impairment. Hydrocephalus, a large head due to cerebrospinal fluid accumulation. Intracranial calcifications, diffuse brain calcifications. And you see here the pictures. Chorioretinitis on your left hand side, in the middle hydrocephalus, and on the extreme right hand side the intracranial calcification in this image. The effects of the infection depend on stage of pregnancy. In the first trimester, that to say the early pregnancy, there will be low chance of transmission. But on the other hand, this may lead to severe outcome if it happens. So the chance of transmission is low in the first trimester, but the consequences will be very grave or serious if the infection occurs. That may lead to miscarriage, stillbirth, severe brain and eye damage. In the second trimester, if the infection takes place in the second trimester, the risk of transmission is moderate, but can cause brain abnormalities like hydrocephalus, eye damage, chorioretinitis. In the third trimester, that's say the late pregnancy, the chance of transmission is high. Often, baby looks normal at birth but may develop visual problem later in life and learning difficulties. Diagnosis, clinical assessment, then laboratory diagnosis in the newborn by serology, taking blood, detection of IgM or IgG, IgA, that's IgM or IgA, if they are positive in the blood of the newborn, they indicate congenital infection because these antibodies cannot cross the placenta. They have to be sensitized in the baby. Persistently high IgG beyond 12 months of age after delivery. We know that IgG can cross the placenta. It may come from the mother, but the maternal IgG should decline and even disappear after 12 months. If the IgG persists after 12 months of delivery, definitely it is sensitized in the baby, and this will confirm the infection. Other investigation like the PCR, that to say gene amplification of Toxoplasma gondii, and that's the DNA in the that can be done in the blood, CSF, urine, and also Toxoplasma gondii can be cultured in tissue culture cells and laboratory animals like mice. Treatment of congenital toxoplasmosis. Treatment is a must. If the baby is diagnosed as having congenital toxoplasmosis, treatment is a must with pyrimethamine, sulfadiazine, and leucovorin. Prevention. Improvement of personal and environmental hygiene. Pregnant women or about to be pregnant should avoid handling raw meat, cats, or their feces without protective measure to cut the road to infection. Regarding vaccination, vaccine development is still on the process, but natural protection prior to pregnancy for months or more is protective. So let us see the effect on the future pregnancies. After first infection, the mother develops strong protective immunity against transplacental transmission. So the future pregnancies, they have low to no risk, may not be infected. The exception is the immunocompromised mother, those who are immunodeficient. There is a possibility of reactivation. I would like to say that the first pregnancy, there is a risk. Later ones, protected. Now we move to the congenital syphilis. Congenital syphilis or syphilis generally is a sexually transmitted infection. The main route of infection is the sexual contact. The causative bacterium is the Spirochete treponema pallidum, and the mother infected by any route can transmit the bacterium from her blood to the baby in the uterus through the placenta, transplacental. Or the infection may occur during delivery due to birth injury. And congenital syphilis may lead to miscarriage, premature birth, stillbirth, live birth with congenital syphilis that manifest at birth or later. Stage of congenital syphilis: early congenital syphilis from birth up to 2 years of age. Here the baby presents with different features like rash, snuffles, hepatosplenomegaly. I will describe snuffles later. Late congenital syphilis, the disease manifests after 2 years of age, often in childhood. Early congenital syphilis from birth to 2 years, symptoms may include snuffles, profuse nasal discharge, which is highly infectious, skin rash, often on palms and soles. So look here, the picture, palm and sole. Hepatosplenomegaly, jaundice and anemia, bone change, periostitis, and lymphadenopathy. In late congenital syphilis, there is Hutchinson trait, which is the hallmark of late congenital syphilis. That to say, the classical picture of late congenital syphilis, the traits are Hutchinson teeth, centrally notched, widely spaced peck shape, permanent upper central incision, so that they appear after, it manifests after the appearance of the permanent incisor. Page shape, so here I put the picture of the page on the left hand side. This is the wooden part, so as to correlate it with the teeth. The arrows are pointing to the these teeth. The neural deafness due to chronic inflammation of the S cranial nerve leading to degeneration, commonly bilateral. Interstitial keratitis, that's in the eye. Also saddle nose, you see here breakage of the bridge of the nose leading to such depression in the nose. And this is a manifestation of late congenital syphilis. Saddle nose deformity appears in congenital syphilis, the late type. You see here. Diagnosis, clinical, the investigations, venereal disease, research laboratory test abbreviated as VDRL, This is non-specific test because the antibody is detected in the blood of the newborn or of the child with the congenital safety. The antigens used to detect are non-treponemic antigens. They are from the uh, heart of the calves, cardiolipins. But the test is very important. It is a phenomenon of antigen-antibody cross-reactivity. Treponema pallidum hemagglutination test here, the antigens used for detection of the antibodies are treponemal antigens. Fluorescent treponemal antibody absorption test, this is also specific because the antigen used for detection of antibodies are treponemal antigen. Then detection of the organism itself, the bacterium, from lesions, placenta, or nasal discharge, dark field microscopy if available, PCR sometimes is needed. That is by gene amplification of the bacteria. The treatment, penicillin, and if there is any defect, they need to corrective treatment or rehabilitation. Prevention, congenital syphilis is completely preventable with proper screening and timely treatment, but can cause lifelong disability or death if missed. And there should be routine antenatal screening for syphilis, early treatment of infected pregnant women, and partner testing and treatment. The sexual partners should be identified and treated. In the effect on the future pregnancy, there is no protective immunity. The syphilis does not confer protective immunity. The future pregnancies are at risk. Risk remains unless treated. The infected mother is treated. And there is persistent risk without treatment. Then we come to congenital rubella. This is a viral disease. Congenital rubella syndrome caused by the rubella virus, which is an RNA virus. The good thing is that it is one antigenic type, so vaccination is affordable. Infection may affect all organs and may lead to fetal death or premature delivery. Up to 85% of infants will be affected if their mothers are infected during the first trimester. So the chance of infection is high if the mother is infected in the first trimester. Congenital rubella syndrome, the child may manifest with deafness, cataracts, opacification of the eye lens, heart defects, microcephaly, very small head, mental retardation, ball alteration, the alteration transient, they appear radiographically, liver and spleen damage. Diagnosis, viral detection in the blood. The good thing is that protection is by vaccination, life attenuated vaccine. Treatment, there is no curative treatment for congenital rubella syndrome. The effect on future pregnancies after infection, first infection, the mother acquires lifelong immunity. So the coming pregnancies are not at risk. Just to emphasize that if infection occurs in early pregnancy, there will be severe fetal defects. Cytomegalovirus infection. This virus is a DNA virus transmitted transplacentally and also in breast milk. The infection leads to premature birth, mononucleosis, and hearing loss. Diagnosis, detection, clinical and detection of the virus in the body fluids, treatment, antiviral drug treatment, so antiviral drugs can be used, but unfortunately there is no vaccine. The effect on future pregnancies after first infection, there will be just only partial immunity. Still, the future pregnancies are at possible risk. Reinfection or reactivation can occur, so the risk persists across pregnancies, unlike toxoplasma. The last one, the herpes simplex virus 2 and 1. This is DNA virus. Infants may acquire congenital herpes from a mother with an active, possibly inapparent herpes infection at time of birth. This disease is not transmitted transplacentally. It is transmitted by exposure, by contact during delivery. The virus, once infects a person, it remains dormant there in the sensory ganglia. There are two types, herpes labialis, known as type 1, and herpes genitalis, that known as type 2. The first one infects the lips, and the second one infects the external genitalia. So if the mother with an active infection delivers vaginally, the baby will get the infection. There is high possibility to get the infection, and there may be localized infection that affects the skin, eyes, and mucous membranes, or it may go to become generalized, affecting the central nervous system, liver, spleen, and eye. So look at the picture here. On your right hand side, this is a classical picture of the herpes labialis. On the right side, on the left side, that is the affecting the eye. Diagnosis: clinical and serological detection of antibodies in the blood of the newborn. Treatment by antiviral drugs. Unfortunately, there is no vaccine. The effect on future pregnancies: the primary infection in pregnancy, there is high risk of transmission. The recurrent infection, the risk will drop due to maternal antibodies. So the future pregnancy, there is risk. The risk depends on the active lesion at the site of delivery. If the mother has active lesion, especially genitals, during labor, the newborn is at high risk of acquiring neonatal herpes during vaginal delivery. And this is one of the indication of cesarean section. Sometimes the baby may be born by cesarean section to avoid the infection by the herpes simplex. So the pattern not about transplacental immunity, transplacental or immunity. It is more about exposure during delivery. By this, the lecture is over. I hope that is understandable, and I wish you all the best.